thyrotoxicosis, which is extremely relevant from a pediatric endocrine perspective and which has got significant implications in terms of diagnosis and management. So we'll try to cover this about various aspects of the thyroid disorders. So we'll start off with this case, 17-year-old girl with neck pain who had a high FT4 and low TSH, was advised methimazole, and she did not have any eye signs or goiter. Now, this is a common presentation, and unfortunately, this child was started on methimazole. While if we look at the clinical picture, it was less likely to be Graves' disease, and in this scenario, a possibility of thyroiditis should have been considered. So, a thyroid scan was done, which showed a reduced intake in that perspective. You can watch on YouTube. So very importantly, therefore, it is that we should really look at nuclear scan in individuals who have got a feature of thyrotoxicosis, especially if their FT4 levels are not very high, if they do not have an eye sign, if they do not have a goiter in that regards. All of you can go and have a look at our website, learning.growsociety.in. You can go and have a look at our web portal, which has got a lot of learning resources which are there. Look at our fellowship courses which are there in that perspective, and the courses including the courses for fellowship and PG courses as well. You can also attend many of our free series which are there in terms of the lecture series, journal clubs, and our publications which are accessible, and also in terms of our app which helps in terms of diagnosis and management at the right time. So today we're going to talk about thyrotoxicosis. I'll touch base initially about the overall physiology. Then Dr. Alapan will talk about the etiological aspects, and then we will have again discussion about assessment management, and Dr. Sandeep will take up forward from some of the Q&As in that regards. So TRH is produced via the hypothalamus, which acts on its receptor to produce TSH action, which then acts on the thyroid to produce T4, which is basically a prohormone. The T4 is converted using monodehydrogenase 1 to T3, and it can be inactivated via the monodehydrogenase 3 into reverse T3. So this T4 is also largely bound to TBG. Only 99.7% is bound and very small amount is free, and T3. So ultimately it is the free hormones which are responsible for the action, and this then acts on the thyroid receptor to cause decrease in the TSH levels. So anybody with thyrotoxicosis, the first thing which should happen is a decline in TSH, followed by a rise in T4, which is the second scenario, which should happen in that regards, and finally T3 will rise. However, under certain circumstances, we can have a rise in T3, which may happen because of increased activity of monodehydrogenase, which results in increased conversion of T4 to T3, especially in iodine deficient conditions, and this is known as T3 toxicosis. So that's why T3 becomes the important investigation. When we discussed last time about hypothyroidism, we said that T3 has got very limited or no value, but T3 is very, very important from a thyrotoxicosis perspective in that regards. So from a pathophysiological perspective, the problem could be in the form of a thyroid receptor stimulating antibody acting on the TSH receptor, which is the classical Graves' disease, in which we will have a goiter, we will have an eye sign, and that's why the size will increase from that perspective. So this will be increased production, decreased TSH, high levels of T3 and T4, and the scan will show the uptake will be on the greater side. On the other hand, if there is a damage to the thyroid gland because of various causes, the preformed hormone, and we know that around 2 months store is there in any gland. This is the largest gland in that perspective. It stores for 2 months. The release can cause transient thyrotoxicosis, which can then improve. Now, this damage is associated with decreased TSH, high levels of T3 and T4, and there will be absent uptake on the thyroid gland. Rarely you can have a problem in the thyroid, in the hypothalamic region, where you can have a TSH producing adenoma, which can cause this scenario. There will be detectable TSH with high T3 and T4. Anybody who has a high FT4 should have zero TSH. If the TSH is there, we have to start thinking of other possibilities like TSH receptor secreting adenoma, which is extremely uncommon in children, or a rare possibility of thyroid hormone resistance in this scenario. Now, thyroid scan will give you a picture of absent uptake in the scenario of thyroid damage and increased uptake again on a TSH dependent scenario. So etiologically, most common cause is TSH independent, and this is usually associated with the antibody, which is Graves, or rarely thyroiditis, less common in children, but also an important consideration as in the first case. We can also have a solitary thyroid nodule, which can produce thyroid hormone, the amount of production is lower here, and usually it is a subclinical scenario, or we can have a multinodular goiter. These are more likely to be present in elderlies. Rarely in children, we can have McCune-Albright syndrome, in which you can have increased production because of the GNAS activation, along with multiple other abnormalities like precocious puberty, fibrous dysplasia, cafe au lait spots, and other scenarios in that regards. So TSH receptor antibody plays an important role in that perspective. TSH dependent causes are associated with detectable TSH because of TSH adenoma. And you can all go and have a look at our website, learn.doctorit.in, explore our books and our application in that perspective. So